Well, good day. I'd like to welcome you to the session, The Role of Good Data, Surveillance, Monitoring, and Evaluation and Elimination. My name is Carolyn Wester. I am the Director of the Division of Viral Hepatitis at the U.S. Centers for Disease Control, and I'm joined by my co-moderator, Professor Jeff Lazarus. We appreciate your patience and persistence while we got started. The prior session overran slightly, so we were accommodating the opportunity for everybody to join our session. We will plan to end on time. Fortunately, that will still leave us with about 15 minutes for questions and answers and hopefully a robust discussion. The description of this, this session is to focus on the importance of data, gaps in surveillance and representation, and how a multi-stakeholder effort can lead to better data collection, interpretation, and dissemination for a more impactful response. The data tools and approaches that viral hepatitis programs have effectively used to strengthen the cascade of care and improve decision-making will be discussed. We'll have 3 speakers. In a moment, I'm going to turn it over to my co-moderator to introduce the first speaker, having a slight change of order. A flipping between our first and third speakers, but all 3 speakers will have a chance to present. So as I turn it over to my co-moderator, I'd like to introduce Professor Jeff Lazarus, who serves as the co-director of the Viral and Bacterial Infections Program and head of the health systems at the Barcelona Institute for Global Health, and an associate professor at the Faculty of Medicine at the University of Barcelona, and a senior scholar at CUNYSPH. He is also vice chairman of the board of EASL International Liver Foundation, has the author of hundreds of publications, and also is working as the group chair of EASL Lancet Liver Commission. So I'd like to turn it over to you, Jeff. Thank you.
Thank you very much, Carolyn, and welcome everyone. Sorry we're getting started a little bit late, but like my co-chair said, we wanted to make sure everyone could be here after the plenary session. My first speaker, as mentioned, we're going to reverse the order, is Professor Jing Sun, who's an associate professor of pharmaceutical policy at the School of Health Policy and Management at the Chinese Academy of Medical Science and Peking Union Medical College. She's also the leader of the Pharmaceutical Policy Theme Group, China Core Group of the International Network of Rational Use of Drugs, and the country leader of the BRICS Medicines Alliance. Her extensive work experiences in national vaccine institutes, regulatory authorities, international health organizations, research and academic institutes all render her knowledge and skills in pharmaceutical science, project management, and policy research. Since 2004, she's been involved in providing technical support to the Chinese government in the pharmaceutical area and contributed to China's national health system reform, especially the reforms in the pharmaceutical sector. The title of her talk is The Uptake of Hepatitis B and C Antiviral Treatment Before and After National Policy Changes in China. So over to you, Professor Sun.
Many thanks for the invitation from the organizing committee of the meeting to invite me share a study commissioned by the World Health Organization. And I'm Jing Sun from the School of Health Policy and Management. So China is a country with a high burden of Hep B and C both. While the existing evidence of treatment of these 2 diseases is limited. It came from a modeling study in 2016 for Hep B and a senatorial hospital study from 2017 to 19 for Hep C, which included only 60,000 samples. So currently, there's no national and provincial treatment data available for these 2 diseases. While aqueous medicines consumption data has been widely used globally for policy analysis, which provided hospital-level utilization data of all marketed antivirals. So consider that hepatitis treatment now in China is still mainly based in hospitals. So this enabled us to make an estimation of standard antiviral treatment of hepatitis as recommended by the national guidelines based on aqueous medicines consumption data. In addition, many national policies implemented in China to overcome the key barrier of availability and affordability of antiviral treatment in recent years, while the impact on adoptive treatment is unknown. So our study aimed to understand the treatment status over time at national and provincial levels, to identify and to quantify the impact of the interested policies. We extracted medicines consumption data by month from IQVIA's China Hospital Pharmacy Audit System from 2012 to 2020 for 6 antivirals recommended by the National Guideline for Hep B and all marketed DAAs for Hep C in China. We measured the consumption of antivirals and the number of standard antiviral treatment in each province over time. We also calculated the proportion of different antivirals used for standard treatment at national level over time. We performed the descriptive analysis of time trends of Hep B and C treatment. We quantify the changes of uptake of Hep B treatment before and after the national policies with quasi experimental designs. We used the interrupted time series method to analyze the first central price negotiation of TDF and insurance coverage at provincial level in 2016. We also used the staggered difference and difference method combined with the event study approach to analyze the pilot food procurement policy of Entecavir and tenofovir in 31 provinces in 2019. From 2013 to 2021, the number of 12-month standard antiviral Hep B treatment in China has been continuously increasing. Entecavir has been dominated the treatment since 2012 when the national guideline was updated in that
Appreciate everybody's flexibility. Thank you. And we'll look forward to hearing back from Professor Sun in just a moment. So I have the privilege of introducing our next speaker. So Alida Njijwe, who is a Senior Program Manager for Infectious Diseases in the Clinton Health Access Initiative in Rwanda, or CHI. She holds a bachelor's degree in biotechnology and a master's degree in international public health from the University of Sydney. Alida has been working in the health sector for over 10 years, both in public and private sectors. She's currently overseeing programs including COVID-19, laboratory services, and the hepatitis program. In the last 3 years, through CHI's support of the government of Rwanda, Alida has been working closely with the Rwanda Biomedical Center to design, implement, and scale a hepatitis program in Rwanda, with a major focus on advancing and achieving the country's hepatitis C elimination plan, which was launched in 2018. Thank you very much. Over to you.
Good morning, good afternoon, and good evening, everyone, depending on where you are. My name is Alida Njijwe. I work with Clinton Health Access Initiative in Rwanda as a Senior Program Manager for Infectious Diseases. I'd like to start by thanking the organizers of this summit for giving us an opportunity to talk about what the country is doing in terms of hepatitis elimination, an agenda that CHI is supporting actively in the country. This presentation will be subdivided in 3 main parts. I'll talk about the background, the current focus, which we have named Closing the Loop, and the next step, which is where we want to be in the near future by achieving hepatitis C elimination. In terms of background, the program was set up back in 2014, and it was followed by an exercise to understand the burden of disease, which was followed by initial service decentralization and task shifting, which led finally to 2018, when the country launched the national plan to eliminate hepatitis C. At that time, a 5-year plan was launched and costed, and clear targets were elaborated to guide the elimination agenda. The country aims at screening 7 million people and treat at least 80% of positive cases. Right after the launch in 2019, the country managed to secure a price record of DAAs at only $60 per cure. At the same time, rapid diagnostic testing was introduced in the country. The two introductions helped a further step in decentralization to health centers and task shifting to nurses. This has allowed intensive case finding, which has contributed to increasing the numbers of people screened and treated. Today, as we speak, all facilities in the country can provide screening and testing services for hepatitis C and B in the country. When it comes to data, the same stepwise approach was used, from registers to Excel sheet to now today, where we are using an electronic patient level system, a DHIS2 hepatitis tracker that is established across the country and is allowing facilities to collect real-time data with comprehensive data analysis at the central level and easy tracking of patients across the cascade of care. The system in place has also allowed to reduce the turnaround time that patients used to spend in the cascade of care. I'll speak about this further in the presentation. There are a few challenges attached to the system, though we think that they will be solved soon. One of them is that it takes long to have the system fully adopted in the country because the majority of healthcare workers are not very conversant with digital solutions and IT equipment. And then we have also a challenge of data that was accumulated in the past from registers and Excel that we need to migrate to DHIS2 to ensure that this data is in one place. So despite all these efforts to have service decentralized, healthcare workers trained, commodities available, and a system in place, this is not enough for the country to actually validate for hepatitis elimination. A monitoring and evaluation system had to be put in place to ensure that there's an actual evaluation of the progress towards elimination. So an M&E system was elaborated with a clear log frame and sustainable measures to collect both programmatic and impact data. Selected programmatic indicators were put in place and tracked across facilities. And there is a regular quality check of data that happens at the central level that ensures that the data we have in the system is of quality, but also the team supports facilities when they need to be assisted. In addition to that, a strategy called closing the loop was designed to accelerate efforts towards elimination. This strategy was named closing the loop because the program went through the different steps of the cascade of care and identified steps where we are likely to lose patients. And at that time, we designed interventions to prevent potential loss of patients. So the closing the loop has two interventions, one of them being the establishment of DHIS2 patient level system that I've just mentioned, that is available at all facilities and can allow to record and track patients across the cascade of care. But also the system is equipped with an SMS component that is sent to patients. So this helps them to come back on time to the facility to collect their viral loads test, but also be initiated on treatment. So the system and the SMS have helped not only to retrieve the patient that could be lost to follow-up otherwise, but also to reduce the turnaround time that patients used to spend. Because in the past, patients would sit in their homes and wait and pass by the facility when they feel like. But currently, an SMS is sent and the patient is brought back at the facility as soon as possible to receive the next step of services. So the two systems are the ones that really we are relying on to ensure that we are fully closing the loop and we are not losing anyone initiated in the cascade of care. Of course, this required IT infrastructures to ensure that all facilities can collect data in real time. And as we speak today, all facilities in the country have a tablet and have internet facilities to ensure that real-time data is collected. In addition to that, we have invested in our capacity building to ensure that the users are equipped with knowledge and they're becoming familiar and conversant with the digital solutions in place. We've trained nurses, we've trained data managers, we've trained lab tech to ensure that the team at the health facility is conversant with the system. So I would also add that this has been facilitated by some of the interventions that were put in place to respond to COVID in the country, because the same digital solutions, DHIS2 and SMS components, are used in the COVID response in the country. So the hepatitis program has built on those initiatives to actually accelerate uptake of digital solutions that the program was introducing. So in terms of next step, the country is also working on finding strategies to measure impact indicators, including incidence and mortality. In terms of incidence, we're planning to retest a cohort of patients who were tested negative back in 2020 and to test them again to evaluate the incidence in that cohort of people, but also building on HIV infrastructure to establish sentinel sites that will continue supporting the program in the monitoring of new hepatitis cases. In terms of mortality, we have already two systems that exist in the country. One is the National Death Registry and the Cancer Registry that we plan to leverage to evaluate mortality rates related to hepatitis. So as a next step, Rwanda has already been involved in the pilot that WHO has recently launched to pilot the elimination guidelines. This was conducted in 6 countries, including Rwanda. And we are mobilizing efforts to ensure that all the data that is scattered in registers and Excel sheets is migrated in DHIS2. And we're also working on the last mile to ensure that we screen and treat the number that is remaining from the national targets that was set. And we have recently introduced a second line of treatment to ensure that patients who may be failing the first line still have an alternative to be treated on the second line. So basically, that's what we have managed to put together. And we believe as a country that we've reached a level where the country can be validated for hepatitis C elimination as we continue scoping for hepatitis B elimination. I'd like to thank you all and happy to take any questions. Thank you.
Thank you very much for sharing the experience from Rwanda. I do see questions coming in the chat, and I'll encourage all participants to keep sending them. But in the interest of time, I think we'll put all the questions at the end when we have a blocked Q&A period. And I'll turn to our next speaker. So I'm delighted to introduce my former colleague from the Global Fund, now at the World Health Organization, master and commander of all things surveillance, Professor Dr. Daniel Lobier will be discussing surveillance for hepatitis, making the hepatitis country data collection systems work better. Over to you, Daniel.
It's great to see you as well, and looking forward very much to presenting. Actually, after the last speaker, because the challenge we saw on the last slide was we've got a big improvement of global data, burden, cascade, and now it really is to use it and to use it at the national level. And I think was shown last time in the district level in facilities to really improve programs. And if you look at our last report, there's been an improvement from 2017-19 to 21. But one of our key messages across the diseases, and it was actually interesting to see this also related to COVID, is to leverage some of these people-centered disaggregated data platforms that we saw in the last presentation. And we really want to ensure that this global effort, some core data, is then used down in the national and in the district level. So I would really start to use the data as we saw in Rwanda, and there is actually improved data in hepatitis, both on the incidence and the mortality. There's a basic package for most countries, and on the gaps in the cascade. And really use the data as was done with the SMS background, talking to patients in the planning to fill the gaps globally, regionally, and in countries. That's really why we've set up the basic cascade data. And you can see the gaps are huge. So even just looking at the latest report, you see where we are at the very early stages really of scale up on HBV, despite the progress towards the 2020 targets. Overall, around 10% diagnosed and 2% of a very large figure on treatment, 296 million people. So we're in really in a stage for me of quite rapid and early scale up in countries. And similarly in HCV, certainly some real progress in the EMRO region, in a number of other regions of the Americas, but globally, when we break that down, around 13% of people on treatment. So it's quite simple data. It's your burden, how many cases there are, the numbers, getting them accepted through the Ministry of Health, and then using them in both the patient and was shown some of the district health information systems to know where you are, identify the gaps, and then try and fill them. And I think there's a certain confidence that should be had, nevertheless, in the hepatitis data. There's a strong set of interventions that, if scaled up towards universal access, have an effect on incidence and mortality. If anything, slightly stronger than in HIV, where you can scale up interventions, and it's quite difficult to have the same confidence on the declines in HIV incidence as we're seeing. So there's a strong investment case on those 6 core interventions, from vaccination, PMTCT, blood safety, injection safety, harm reduction, testing and treatment. And we know if we scale those up, we will also see declines in incidence and mortality. But there is this balance between the improvements that we're making and some of the ongoing weaknesses that we need to address, both globally, regionally, and in countries. So some of the improvements is actually to collect a lot of the existing data that is there. So we have a strong now partner consortium. We really do want to thank Homi and Sarah. We have IHME, regular meetings, IARC working with us as part of WHO, Bristol Imperial. There's a basic set of data that we've now made available to countries. We've also simplified the algorithm for country reporting. So it's really based on country data and validation. But some of the basic background data is also made available that people could begin to use for planning. And this has led to quite an improved scope of country reporting, to around a basic package of around 130 countries from all of the regions, which we would like to see validated and used within countries. And part of that is trying to simplify the data. So looking at what is the data that is used, as was shown around, it's quite straightforward data on diagnosis, on treatment, and then improving that burden data on mortality and incidence. But there are some ongoing weaknesses we're trying to improve. First of all, we're recognizing the important priority of hepatitis B and further aligning the burden data in terms of estimates and the natural history. Looking at the HCV incidence estimates and the continued role of unsafe injections in medical situations and beyond, which are contributing to infections. Private sector data is necessary in most countries on the drug data and diagnostic data, and also on the pricing and the costing. And then, although we have the basic guidelines, and Diana here is supporting this, it is the strengthening in a stepwise way, and I'll come to that, the country surveillance, and using this opportunity to build, as we've seen in Rwanda, the data from the national level into the districts, in the facilities where decisions are made. And there's some important major countries when we look at the stage we are at now, which is one of scale up. Some of those big countries: India, Indonesia, Nigeria, DRC, Vietnam, China, Pakistan, Ethiopia, South Africa, Bangladesh. An increasing focus on lower middle income countries, where we need to ensure that we use data to get quite rapid scale up in this in the coming years. So this very briefly is how we've got together that data from 130 countries, and it's got 2 steps to it. On the top, it takes data from the Ministry of Health and from countries And we also bring together all the existing sources and make them available to countries to try and fill in the gaps. It is based then on a priority on country validation, so testing the data, showing the weaknesses, also using the opportunities to strengthen country surveillance, and then regional and global validation, with a really focus on a basic set of data that's now available for country planning, for the investment cases, and for the work within countries to support that scale up. And you'll see some of the increase over the last few years. That's the map of the data reporting 2017, and big improvement towards 2021. There's still a major scope to improve data quality in the sub-Saharan African country data systems, and it's great to see some of the examples there. And we do want to focus some of the partners who work with us on this in those countries. That will be the focus of our partner collaborative meeting. And there's really four things when we look at the simplification of reporting. We've simplified the tool. So there's one page of data. It's using quite simple data sources, but being able to bring them into the patient forms, into the DHS2 and national reporting. Trying to improve the alignment of partner data and making that available to countries. An ongoing schedule of country validation. So where we can, working with countries. And again, it's all of our partners, CDF, Imperial, many other partners working in countries to try and cover the high burden countries, and then also improving some of the overall estimates as we saw the investment in mortality and in incidents. And really to try and leverage that so that we get the same indicators used globally, but they're drawing from the national and, as we've seen, into the district level, and do that in a stepwise way. And that's probably how we're going to shape some of the improvements in our guidelines. First of all, just to use the data that's there, to look at it, to challenge it, to look where we can improve it. The burden of HBV and HCV data is there for most countries. It often requires validation. It's got gaps. It's got inconsistencies. But to start by using the data for planning, let's say you see some of the gaps, how you can build it for improving services. Then strengthening the burden and the cascade data. A basic survey of burden, which can be including HBV and HCV in existing surveys. HIV, we've got an opportunity, DHS, but we also saw some of the work in COVID. Establishing a basic treatment cohort, which is consolidated, deduplicated. Pathology centers are obviously often a basis for this and is updated regularly. And looking at the percentage diagnosed on treatment, so we can often look at that first cascade before we look at the more difficult stage of diagnosed testing data, and assessing the mortality outcomes among people on treatment. Then we can use that for some of the natural history and some of the outcomes. And then thirdly, the drug data, adjusting data with the consumption data for a country from the private sector. And that's the first bit we really stop at to say, again, then use the data. The above is sufficient for the planning, for the important resource mobilization, and for the gaps in modeling. But then the two other pieces stepwise, as we've seen in the presentation so far, is to strengthen that person-centered routine data, build the indicators into the patient forms, input where possible into the HMIS, and where there's electronic into the DHS2 allows more real-time use of the data from the facility districts and consistency at the national level. Look at the completeness studies and really start to use the data so we get that demand-driven data improvement within country systems. And then, as we saw in the last in the last slides of the presentation, strengthen the outcomes analysis. We have a very strong model from services to incidence and mortality and hepatitis, but strengthening the cancer registries, triple fractions, improving the burden for your country, and looking at where the sources are of new infections by population. And that really is the stepwise state. There's a lot of guidance, but we want to ensure that we can strengthen country surveillance with the new data. And those are some of the planned improvements for this year. At the global level, we will be aligning the HBV and HCV burden and looking at the HCV incidence and using drug and diagnostics forecasting and costing more fully across the countries and with our partners. And in the country, it is to consolidate country reporting to see if we can have those validated for planning within ministries of health, because there's much more data there available than is often used. aligning partner data, surveillance support, at least in our team and partners for some key countries, and then further consolidate and show this stepwise approach for improving surveillance within countries. And that's really the conclusion. There really are some major improvements in viral hepatitis data. There's big gaps, but there's also certain confidence that it can be used for planning and for country reporting, and to continually improve the estimates and then that cascade of testing and treatment. So improving the validation and the use of data. We want to also thank the partner collaborative that has been very important globally, and now we really do want to focus them on some key countries, improving surveillance and the data we get from countries and validating it. And then we have a lot of the guidance, but it will be around simplifying and showing the stepwise process to build country surveillance, the sequence of actions that we can ensure so it's built into district and facility data systems. And I think, as we were shown in the last presentation, I mean, the focus really is on using the data we've got to identify the gaps, to build country surveillance as we do reporting, and to support those services within countries. Thank you.
Thank you so much, Daniel. When I hear about the challenges of data collection and then the challenges of data quality, one can despair a little bit, but we've heard of some good presentations here during the summit. And we also know that 10 years ago, we weren't collecting data at all. So we've come incredibly far, and thank you at WHO for leading this effort. I'm going to ask Dr. Sun if you can try and share your slides and pick up where you left off.
I'm not sure if you can hear me now.
Hear you.
Yeah, I'll try to share the screen and to continue the slides where we.
Yes, you're live, by the way.
Yes, for the hepatitis C. Can you see the slide?
We see the slide and we hear you, so please continue. Thanks so much.
Okay, so let's continue. Sorry about that. So in 2017, that was the year that the first DAA was marketed in China. 2020 was the year that the first DAA was covered by the National Health Insurance Program. And the sulfosbuvir and combined with velpatasvir was the first pan-genotype combination of DAA covered by the health insurance. Before 2020, there was very few cases of treatment of C using DAA, and sulfosbuvir and velpatasvir was the one that has been dominating the treatment. And there was another treatment, clopidogrel, that was marketed, that was covered by the health insurance in 2020, that was developed by the local company, and that lead the treatment cost, DAA cost for 3 months treatment, lower to less than $200 for patients. So you can see that the treatment with this product has been keeping increasing since then. So evidence generated by this study showed that in 2021, there was 3.2 billion 12-month standard antiviral treatment of Hep B in 2021, and the 50,000 3-month standard DAA treatment of Hep C. This graph shows the Hep B treatment time trends in 31 provinces from 2012 to 2020. You can see that there were faster growths in 2016 and 2019 in some provinces. So we targeted few policies in this respective year. The first, the central price negotiation and the pilot food procurement. These two policies lead the treatment cost of Hep B reduced from $3,000 to $900 and further to $30 per year.
Dr. Sun, we can no longer hear you. So I think we're having the same issue as earlier. So I'm going to suggest that we go to the question and answer. Since we only have a few minutes, and I'll pass over to you, Carolyn. There were some questions that came in via the platform.
Great, thank you very much. Professor Sun, thank you very much. I'm sorry for the technical difficulties that have been experienced, but we look forward to seeing your presentation. I know that the presentations will be loaded for folks to see in the days ahead. So we look forward to being able to review your presentation fully at that time. So with probably about 5 minutes before we wrap up, I see several questions in the chat. The first one I wanted to pull out is that someone indicated that during a presentation earlier in the summit, it was mentioned that hepatitis is a notifiable disease in several countries. And the question was posed, would such a legal measure help improve surveillance, or should we be concerned about unintended consequences and potential harms? So I would love to hear any feedback from individuals within this session. I'll just begin and kick it off. Within the United States, hepatitis A, acute and chronic B, and acute and chronic C are notifiable diseases. And the advantage that we see for that, each state makes their own jurisdictional decisions about that. But our reportable diseases, sometimes the nuances are what labs that support those conditions are reportable in and of themselves. We are actually pushing, and I'll use C as a context, to encourage state jurisdictions to make not only the conditions, but actually all supporting labs, including positive and negative hepatitis C RNA results reportable as part of those conditions. And we see the advantage from a system-wide approach because we can use surveillance data, particularly lab result data, to develop clearance cascades based on lab results. So in addition to the national level data, the jurisdictions can then use that information through validated clearance cascades based on lab result data in order to see how their jurisdiction's doing, and then subcategorize it by different demographic characteristics or even comorbidities. Further, at the person level, that individual case information can be used for data to care. So to reach out to individuals for early detection and response for outbreaks and for collecting risk factor information. So there are benefits. I think that from a harm standpoint, at least in the US, those conversations have been more about the use, not of the reportable conditions themselves or those supporting labs, but more in the context of molecular surveillance. So anyways, I will leave that right there. And I don't know if there are any individuals who would like to raise their hand or make additional comments in the chat on that comment. Jeff, I'll look to you. I don't know.
Yeah, I don't see anyone raising their hand, but I certainly think making it notifiable makes good sense. I mean, that's how we're going to get this information. It's requiring it versus leaving it voluntary, and reporting it voluntarily hasn't been working so well. I also think when it's notifiable, it draws even more attention to it because it then goes into electronic medical records where they're available. It goes into paper lists of notifiable. It becomes a change that gets communicated to healthcare workers, again, raising awareness. So I do understand the concern about possible harms, but I think the benefits far outweigh it because, as Dr. Lobier was showing us, we know the numbers for HPV that are diagnosed are still so low, around 10% globally, and only 2% on treatment. So we have to do something rather urgently.
And I think the one other piece that I will say is, and I'm just going to use acute hepatitis C as a case kind of study for that, is that it does not replace the need to do larger surveillance efforts. So for general population as well as special populations like people who inject drugs. So for example, in the United States, acute reporting, we still have an adjustment factor for under ascertainment and under reporting of acute cases. So while we follow reported acute cases very closely, we know that with more than 70% of acute infections being asymptomatic, there's going to be under recognition, not only by the clients, but by their providers. And then there's going to be that will trickle down into underreporting. So I think it's a very, very valuable adjunct, but it's not going to capture all the information that you need. Okay, because of time, I'm very sorry that we have to cut this short, but really appreciate and would like to thank again our speakers and for all of you for attending. I'd like to thank my co-moderator, Professor Lazarus. And now that we're closing, I'd like to direct you, the meeting organizers have asked us to have you, once you exit this, go back to the agenda. There's a poll apparently that is sponsored by Roche, one of our sponsors, that can be found on the agenda. And there's a button to take the poll. So they're very interested in hearing your thoughts, and we would appreciate if you would participate in that manner. So on behalf of Professor Lazarus and myself and the organizers, thank you again for joining us. Have a great rest of the day.